Maintenance care for chronic low back pain. Is it necessary, and if so, how effective is it? Let's look at a very interesting study, the first randomized trial to truly approach the question of whether maintenance care utilizing manipulation has an effect on chronic low back pain patient outcomes. The study is published in Spine. It's entitled, Does Maintained Spinal Manipulation Therapy for Chronic Nonspecific Low Back Pain Result in Better Long-Term Outcome? Generally, this is a well-designed, well-executed study that provides good starting evidence for the value of maintenance care for chronic low back pain utilizing manipulation compared to standard episodic care, meaning care delivered for only the acute episode. Also, this study incorporated a control group that was exposed to sham manipulation to test the possibility of improvement simply through natural history or placebo. Well, don't start celebrating yet. Like all studies, there are strengths and weaknesses. No, don't get frustrated. Let's take a closer look at how the study was designed and how improvement was measured and compared across treatment groups. It's important here to clarify what nonspecific chronic low back pain is, especially as defined for this study. In essence, nonspecific chronic low back pain is exactly that. It's low back pain not explained by any specific pathology, such as infection, arthritis, tumor, etc., nor is it due to known spinal pathology, such as a herniated disc or other causes of nerve root involvement. Although we tend to think of disc or nerve root involvement as comprising a large part of a standard patient population for chiropractors, a study by Deo and Phillips indicated that nonspecific chronic low back pain represents 85% of low back pain patients, at least in primary care. So based on this definition, exclusion factors could be applied to patient qualification for the study. Excluded from the study were patients with red flags, patients with signs of nerve root involvement, cases of fibromyalgia, and patients older than 60 or younger than 20, or prior experience with spinal manipulative therapy. Interestingly, other disqualifiers were obese patients, those with prior psychiatric problems, and pregnancy. Those selected were given a full musculoskeletal and neurological examination, full lab work, and lateral and AP radiographs followed by MRI of the lumbar spine. These were all done in an attempt to rule out specific disease of the lumbar spine. Patients were randomized into 3 groups. One group received 12 treatments of sham SMT over 1 month. Another group received 12 treatments of real SMT over 1 month. And the final group received 12 treatments of actual SMT over 1 month and maintenance spinal manipulation every 2 weeks for 9 months. In addition, patients were given pelvic tilt exercises to be performed after the manipulation or sham manipulation, consisting of 10 repetitions after manipulation and 10 repetitions 3 times daily. Now here's where things get interesting. The description of the manipulation is not the typical side posture approach. The description actually states that the therapist passively rotates the patient and delivers a quick thrust to the anterior superior iliac spine in a posterior inferior direction. Now that certainly changes everything with regard to extrapolation to chiropractic manipulation. Let's continue though. The researchers made every attempt to measure all aspects of patient well-being and improvement, including a visual analog scale, the 100 millimeter version for pain, for function, the Oswestry disability score, and for general health, the SF-36 questionnaire. For an objective measure, they included measurement of spinal mobility using the modified Schober method for flexion and lateral bending measurement. They also included patients' global assessment of their improvement using a 1 to 5 scale, best to worst. Measures were performed at baseline, at 1 month, 4 months, 7 months, and 10 months. What is undeniable is that this study has good statistical strength within and among groups. There are clear statistical differences among the groups with a clear positive trend in improvement for the SMT and continued maintenance care group over the other 2 groups across all outcome measures. Also, there is a clear statistical difference between the 2 groups who actually received manipulation versus the sham manipulation group. Of course, there is still the question of clinical relevance. Are the improvements significant enough to be appreciated by patients? compared to baseline, and most importantly, are these differences large enough among the groups to declare a winner? Well, one obvious measure is the patient's global impression. So let's look at that. Although we can say that 65% of patients in the maintenance group rated the lower back status as much better or somewhat better, that only equals 13 patients, compared to 7 patients in the real manipulation but no maintenance group, and more telling, the 6 patients in the sham manipulation group, all rating their improvements similarly. Again, this is a clear difference among the groups, but not as dramatic as one would hope. Inadvertently exposed here is the small size of each treatment group. The power of the differences would be much more significant had each group been even double or triple the size. But this is still a good initial effort for perhaps the design of a larger study. Now, let's look at the actual number differences as means among the groups to see the magnitude of difference and again ask the question whether this would likely be noticeable or considered an improvement that is meaningful by the patient. In a recent editorial in Spine, Gatchel et al. Argue that the minimal clinically important difference, or MCID, is inherently statistically flawed, requiring an independent measure. The example they give is a study by Wilson et al. That clearly demonstrates that changes that meet the MCID requirement for Oswestry and SF36 did not translate into a correlation or predict the external measure of return to work or work retention status at 1 year. They caution about using only measures that are not independent of each other. In any case, let's first look at the VAS, the Visual Analog Scale. The MCID for 100 mm VAS has been estimated at 18 points, meaning a change of at least 18 points. In the current study, you can see the differences in the VAS at baseline and at the final 10-month follow-up. It's clear that improvements are notable in both real manipulation groups and continue at the end of the 10-month follow-up. The improvement in the maintenance group did exceed the 18-point threshold and did not in the other groups. In fact, the other groups regressed. For the Oswestry disability scores, the baseline scores were all in the high moderate disability range. At the end of the study, the only group to enter the minimal disability range was the maintenance group. For the SF36, we simply don't know what the MCID should be, but we can say that there was a significant change between the maintained group versus the others, although how clinically relevant, it's hard to gauge. It's unlikely that the small differences in flexion and lateral bending of at best a couple of inches would translate into much of a functionally noticeable improvement for the patient, at least between groups. Although this is a good start, the small number of patients reduces the power of the study for drawing strong conclusions and limits the confidence in extrapolating to the general chronic low back pain population. The authors admit that total blinding of the patients was not possible. This partial blinding of subjects was dealt with through an attempt to decrease possible interaction among participants, but those going on to the continued maintenance care made the difference obvious. The authors attempted to decrease the effect by not biasing patients to any benefit for assignment to any particular group. The authors admit that there are clear problems with missing data. Instead of simply disqualifying that individual, called list-wise deletion, they approach this through a process called multiple imputation. This is a statistical process which replaces missing values based on trends and adjusting for differences between responders and non-responders. The most important concern here is that the manipulation procedure is not one utilized by chiropractors and should therefore limit any extrapolation to the typical side posture used, which literally applies force application to the opposite side of the pelvis and therefore in the opposite direction. Perhaps both accomplish the same goal, but this has not yet been demonstrated. Let's summarize. The study was well designed with no obvious baseline differences among the randomized groups. Statistical significance was always achieved in the outcome measures. Trends indicated improvement for the maintained group versus the other two groups. It could be argued that these changes are clinically significant, certainly for the changes in disability. This study should serve as the template for a larger study that utilizes a standard chiropractic side posture manipulation to determine effectiveness both as a comparison to sham manipulation and to determine the value of maintenance care over acute care only management.